Okay, welcome everyone. Thank you for joining us today for ISA Presents. I'm Sue Steen. I am a secretary on the board of ISA, and I have known Neelam for many years through ISA, and I would just like to read you her introduction. Neelam is a clinical professor of obstetrics and gynecology in India. She's president of the Stillbirth Society of India, a member organization of ISA. Neelam started a multi-centric facility-based stillbirth surveillance at PGIMER, and I don't even think I can pronounce that name right, but she can maybe pronounce it for us in collaboration with the WHO, the SEARO, and she was PBI with the Indian project and is now promoting bereavement care in India and elsewhere. And her topic today is stillbirth surveillance and review in India from project to program. Okay, I will let you welcome Neelam. We're glad you're here and excited to hear what you have to share with us today. So go ahead and begin.
Okay, thank you so much. Thank you, Sue, for this kind introduction. So I'll be just talking about how we started just as a small project given to us by WHO SEARO in 2011 and where we have reached in these last 14 years. So before starting, I must acknowledge the people who have helped me in putting this all together. So first and foremost to our funders, WHO SEARO, Dr. Neena Rana and her team, which included Dr. Rajesh Mehta, Dr. Anoma, and many others. And then my institute, PGIMER Chandigarh, where the Department of Obstetrics Gynecology and Neonatology, and then our 20 collaborating centers mostly from the northern India, who were all this was funded. I must tell you that this project was all throughout for those 14 years funded by WHO SEARO. So it's totally Dr. Neena Rana's help which has brought us here, and also in PVI toolkit which we did with ISA, and here also for India component India PVI India toolkit that was funded by WHO SEARO, again Dr. Neena Rana. Thank you, Dr. Neena, if you are there in the audience. So I'll just tell you about the India story. So I don't know why this is not working. Can you see the slides?
Yeah. Mm-hmm.
Yeah. So before we go with India story, let me just in a couple of minutes tell you about the global scenario, because stillbirth still is not that well recognized as it should be, right? So we will start with the global scenario. So in global scenario also, stillbirth was brought out of the shadows by first Lancet series in 2011, and there was global awakening along with this Lancet first series on stillbirths, and there were many international meetings breaking the silence around stillbirth. So this was the first series where this hidden reality was shown and call to action was given by Lancet 2011. And you can appreciate here they had reported around 3.2 million stillbirths globally annually, and 98% in low and middle income countries. So then this was the second series this is the 2020 neglected tragedy, and before that 2016 series was also there. This is UNIGME, which is now coming every couple of years with the global and regional estimates by country wise. So we will start with India story. So let me just show where we are today, and we will retrace back. So just on July 18th, 2025, barely 2 months ago, Government of India, Ministry of Health and Family Welfare, they have released operational guidelines for facility-based stillbirth surveillance and response. And the good thing is that this is going to be incorporated in all public health facilities in the HMS program, so that stillbirth data and review of causes is automatically done, and we are able to have a clear view where our stillbirths are occurring, why they are occurring, and what should be done to prevent them, right? So how we reached here today? So let us retrace our steps back to 2011. So as all of you know, even 1,000 miles long journey, whatever is the length of the journey, it starts with a single step. And this single step we took in 2011. This series where you can see this article from India in 2011, Stillbirth Progress and Unfinished Business. Here also it was shown that stillbirth is still in the shadows, not much talked about. So how we started in 2011, there was a World Health Assembly commitment to work on congenital syphilis and to eradicate stillbirths due to congenital syphilis. And then they had told us to report syphilis related stillbirth, and to our surprise, there was no data about syphilis. Owing to the limited data, it was very difficult to assess the congenital syphilis and birth defects due to this disease. So in India, it started as an offshoot of the WHO project on global move for elimination of congenital syphilis. And standard database was initiated as a collaborative effort by WHO SEARO and our own institute in 2011. So because of the invisibility, there was a mismatched burden, because whatever is out of sight is out of mind. So because nobody knew about the importance of stillbirths, and so there was not much data and much record about this. Until the burden is clearly known, no concrete action can be taken. So there was a need felt to make standard protocols for the surveillance, so as we could generate data for preventing, planning, and effective interventions to reduce stillbirths. So this was done with support of WHO and our own institute. So because purpose was to have a logical starting point for counting the numbers. And for counting the numbers, we needed to have protocols at the sentinel sites. To begin with, the referral institutes, where there was a large delivery load, and then to navigate the whole health system in future. And so I am happy to tell you that with our efforts, we could standardize the protocols and the tools for sentinel surveillance of stillbirth. And now with the release of these operational guidelines, maybe it is hoped that we will be able to navigate the whole health system in India in the near future for stillbirth numbers. And but when we started, there were huge challenges for making stillbirth protocols, because there were no numbers, definitions were varied, and there was a classification bias, which classification system to be chosen for giving the cause of stillbirth. And as you must have seen that this standing for stillbirth report of 2025, UNICEF report of 2025, now they have also clarified that the standard UN definition for stillbirth is the 28 weeks and above, and which is taken as late gestation stillbirth. So we have also taken 28 weeks and above in our protocols. So making stills a viable count was a very big challenge ahead, as I have told, and the real difficulties are that we are not able to identify, and this is, I think, world over, stillbirth and early neonatal death. That's very, very confusing. Pediatricians try to label it as stillbirth, obstetricians as the early neonatal death, but whatever, whether it is early neonatal or stillbirth, mostly causes are the same. So we need to focus on those causes and try to bring about interventions for those. Then potentially modifiable risk factors are also different. For example, in high income group countries, obesity, overage of the mother, smoking, etc., those are the main causes for 1/3 of the stillbirths. But if you see, all fauna and flora of each continent is different, so similar is the cause for the stillbirths. So we have a different risk profile in LMICs, especially because due to lack of skilled attendants at delivery in in many countries of LMICs, low socioeconomic status, poor nutrition, previous stillbirths, infections, then hypertensive disease of pregnancy. These are the main causes in LMICs. And continuing with our surveillance, this was the first operational guidelines for establishing sentinel stillbirth surveillance system in June 2016. But somehow it could not got translated into incorporation into the HMIS systems. We had multiple meetings for all these protocols with different experts and brainstorming sessions. And these were the sites all over India which were participating for the data collection. And these were the sites which were from government side, which were reporting birth defect surveillance, and there we tried to incorporate stillbirth surveillance also in these 55 government approved sites. So translation into clinical care for all these protocols was to identify at high risk cases for stillbirth, and careful attention to blood pressure record and complications, careful watch for intrauterine growth retardation and fetal surveillance, because main causes found in our population was hypertensive disease, fetal growth reduction, and infections. Intrapartum skilled care, and then it was seen that need of respectful bereavement care was also unmet. So these are the major milestones for our surveillance 2021, from 2011 to 2025. So 2011 we started with the protocols. 2014 there was Southeast Asian region NBBD established database by WHO SEARO for prevention and control of birth defects in Southeast Asia region, where we incorporated the stillbirth surveillance also. And then Government of India pitched in from 2022, and these guidelines for stillbirth surveillance were being finalized and finally released on 2025, and with regional trainings have also started for capacity building of the healthcare workers for the same. So then second part was, this was the protocols and toolkits for making sentinel site stillbirths and public facility based stillbirth. Second part is the giving support to those who are bereaved. So bereavement support. So in bereavement support, we had with ISA collaboration, Parent Voice Initiative Toolkit. So it was a PMNCH funded project where ISA was participating, and Parent Voice Initiative, it was to raise the voice of affected parents. This toolkit was to be made. So ultimately there were two countries where this was to be made. One was Kenya and another was India. Our protocols and toolkit for counting the stillbirths, and then we found out that just counting the numbers was not enough. It was like putting your underfed cow over the weighing machine again and again, thinking that she will gain weight, but you need to know the reason. So that's why we went into stillbirth surveillance and review. And from there, we finalized the protocols for causes and classification system. And so then that means we had the data, and we will have the data as well as the causes, and we can plan our interventions according to the causes. So now second is the service delivery part for those who have been bereaved because of stillbirth. So for those families, they need to have bereavement support. So in the bereavement support section, we had PVI Toolkit India in collaboration with ISA, and PVI Toolkit India was Stillbirth Advocacy Working Group Parents Voices Initiative, where raising parents' voices advocacy toolkit was the aim. But when we decided to do it in India, we found out that even our healthcare workers were not yet so much sensitized about the bereavement care. So we thought we will first make in India version, we will make it for the health providers. So we made PVI toolkit for health providers in India. This was in collaboration with ISA, Public Health Foundation of India, PHFI. Rakhi Dandona was there. Rakhi is the vice chair of ISA. And then this was London School Hygiene and Tropical Medicine, where Hannah is there. And then this was PGIMER and Stillbirth Society of India. Members were also present for these toolkit workshops. So we held 2 workshops before finalizing the PVI Toolkit India. One was with the public health facility healthcare workers, where in public healthcare facilities, workers were giving care to the stillbirths. And second were the private facilities healthcare workers. So these are our Zoom meetings. All these 2 meetings we had Zoom meetings, and here we had from national, means from India, as well as we had our people from ISA also participated in the PVI toolkit workshops to give their opinions and we made this PVI toolkit India. So in phase 1, it was development of the toolkit, adapting the toolkit for in-country specific socio-cultural settings. So we had first workshop with tertiary healthcare providers, and workshop 2 was with primary and community level healthcare providers. So Zen was Zen was very instrumental in this PVI Toolkit India development. Then based on the workshop findings, revision of toolkit was done, and finally PVI Toolkit India was released in 2022. So in the phase 2, it was decided to have field testing of this with bereaved parents and presenting the toolkit to the bereaved parents with in-depth interviews and FGD workshops, and then revision of this toolkit. But unfortunately, phase 2 part is still pending because of the lack of funding. We didn't get any funding so far for this phase 2, and we are still trying that whenever we get some funding for testing, field testing of this PVI Toolkit India, that will be very good. So these were the themes from phase 1, that training of healthcare providers involves efforts towards a prevention of stillbirths, provision of bereavement care, and care in the next pregnancy after this stillbirth. This needs to be initiated by taking small steps in all the fields in continuity and simultaneously. Community involvement is a must to understand the community responses for final revision of the toolkit. Then good communication is the key to break the bad news and deliver effective bereavement care. Continuity of care and consistency in approach by training of the whole team who are taking care of a bereaved woman. Then family involvement along with the parents and providing a dignified care to the stillborn baby, and respecting the parenthood feeling even in the absence of the live baby, and recognition of stillborn baby and registration. So all these themes have come out from PVA phase 1. Here parents have not yet been involved. This is only the healthcare workers from all fields, public health facilities as well private and community health facilities, healthcare providers. These all themes have come out from phase 1, and PVI toolkit is from these tools. Now this toolkit needs to be field tested in future with the healthcare, with the bereaved parents, and then only we can have a effective toolkit for raising parents' voices. And hopefully we might get some funding and we can start this work. And while making this registry for the support groups, that also was the PMNCH initiative. It was found that in India, there were hardly any parent support or bereavement care support organizations in India, except for SBSI, which was the only registered body for bereavement care. And this registered SBSI was started in 2021. This is the first formally registered society, got established in April 2021. Dr. Tamkin Khan from UP is the Uttar Pradesh, which is the most means worst hit state, one of the most hit states by stillbirths in India. So she established this in April 2021 with aims to spread awareness on prevention of stillbirths and help parents and families to raise their voices and to provide standardized bereavement support and care to parents who are affected by stillbirth, conduct research and gather evidence to strengthen the bereavement care and healthcare provision strategies to parents affected by stillbirths, specifically in India, because culturally specific context to be used. So motto is preventing death before birth, and this is affiliated to ISA. So this recently we have had 3 annual, because the society was established in 2021 and formally inaugurated in August 2021, and we have had since then we have had 3 conferences annually. In 2023 first conference at Chandigarh, 24 second one, and recently just couple of months back we had this in 2025 in UP Lucknow, SBS Icon 25, and Paula was one of the invited keynote speakers in this conference, and she presented the global scenario on stillbirths. And we had a 3 hours long bereavement care workshop in this conference. And then we had a big training workshop for empowering healthcare workers, especially our ground level workers, community level workers, ASHAs. We had 650 ASHAs trained in this workshop in our Stillbirth Society of India conference, and 650 community health workers in the first conference. And we plan to hold such trainings in future, so as to, we hope to navigate this to as many regions as possible, because these community health workers, if they are trained well for taking care of these women, this will definitely help in prevention as well as providing the bereavement support care to these families, parents and families. So, and another thing, what Stillbirth Society of India, Dr. Tamkin had this with UNICEF, this project, deep dive into stillbirths, where review of stillbirths from 5 facilities of the state and along with verbal autopsy was done, and it was found that there was lack of awareness and very poor quality records and mismatched records. Intrapartum stillbirths were recorded as antepartum stillbirths, whereas when the parents were called and verbal autopsy was done and pictures what parents had taken of the baby, it was seen that most of the intrapartum stillbirths were shown as antepartum stillbirths. This was because of the logistical problems. So this is very clear that we should have accurate numbers and accurate causes, and then provision of the support care. So for all this work, we acknowledge WHO SEARO, all our collaborating centers, our institute and Government of India, who have helped in coming, and now we have come so far that we will be able to maybe navigate the whole HMIS system in India for the stillbirth numbers. Thank you.
Thank you, Neelam. That was a wonderful presentation. So much you have accomplished in India, a model for many places. We want, if you would like to stop sharing your screen, we would like to invite everyone to have a chance to ask questions. And I also want to make sure Marty has asked for a link, Neelam, if there's a link to your operational guidelines. Do you have any links to guidelines that you would want to share in our chat? Or is it something we could follow up with for people who are interested? That's one of the questions in the chat.
Yeah, okay. So this has been just released 2 months back, and I will have to check with the Government of India personnel for whether we have the link and whether we can share it right now
Okay.
publicly or no. Because
Okay. That is,
we have just started the first regional training we have done for one
Mhm.
region. In the south we have done this, and because it's a government document, I will just find out, and if there is at any time that it is available, I will definitely, I don't think there should be any reason not to share, but I have to get the permission and the link
sure.
from, yeah.
Yes, sure. Okay, so it looks like, please, everyone, feel free to ask your questions. It looks like people are asking some questions in the chat, Neelam. So let's look at
Yeah.
those.
Yeah,
One is,
I can see Dr. Neena Rana, who has been the mastermind, I would say, behind all this.
yeah,
So I would invite Dr. Neena Rana to please comment and for to navigate the past, all this past experience, and how to navigate in future our healthcare system, so that we can have a better means whatever is our aim reduction, that INAP EVENE. First, the previous INAP everybody knows now, it is every woman every newborn, rather than every newborn action plan. It
yes.
is now EWENE. So Dr. Neena, if you could please just throw some light, because you are the person behind all this. Dr. Neena, please unmute yourself. Unmute, please.
Yes.
Thank you so much. And I think distinguished participants who are here, and I see some of the real stalwarts like Paula and Sue. I would say that, yes, the journey has been so very well explained by Dr. Neelam. It's a long journey, but all the more reason, I think, for us to start. The start had to be made somewhere. So, first of all, very, very grateful to you, Dr. Neelam, for your leadership. Not only for India, because we were doing it in Southeast Asia region, and she had been to other countries also. And during most of our meetings, her motivational talk and her commitment, dedication was very, very useful to not only motivate but also strengthen capacities in small countries like Maldives, Nepal, Bangladesh, Myanmar. So I think we have this stillbirth surveillance going on in many other countries as well. Uh, so I'm very happy that from the project which was conceived almost a decade and a half ago, we have been able to, at least in India, has taken the lead to prepare the guidelines and especially facility-based guidelines. So we did not only stick to surveillance. I see that bereavement care, patient voice initiative, all these things really are going to shape up. And Stillbirth Society of India has really contributed in a big way, including International Stillbirth, Alliance or Society. So I think now the challenge is, yes, we know counting is important. If you don't count, you don't know the magnitude of the problem. I don't call it burden, but it's the magnitude which is important. We need to move beyond counting. And I see that there is a antenatal care, the bundle, the package for prevention of stillbirth, which Stillbirth Society of India is promoting. These are some of the very challenging and interesting developments and interesting times. Implementation to scale remains a big challenge. Stillbirth always falls in between the cracks. Obstetricians feel that it's not our area, because I really face a lot of problems. And thanks to Dr. Neelam for taking the lead as an obstetrician. Pediatricians and neonatologists never felt it was their baby. So I think it has always fallen in between the cracks, and that's why we have not been able to make the kind of progress. And it took us so long But I'm very glad that we are there, and thanks to all the people who are connected here, shows their dedication and commitment. WHO, as WHO, we have not yet given. I've retired just a year back, but I still continue to support stillbirth, surveillance as well as prevention efforts. We need to focus on high-risk pregnancies, in a big way. And I see that intrapartum, lot of. I was reviewing the data, the village, the rural data. I'm the executive director honorary for one of the institutions called Foundation for Survival for Women and Children, called SWATCH. So they have heaps of data. I think they have about more than 400,000 pregnancies being tracked. It's a huge data they have. So I was looking at the data, and in one of the blogs, the stillbirth rate is 24, but the neonatal mortality is 9. In a cluster of village, and I'm talking of about, when we say block, it's around more than 200,000 population. And I say, why it's happening? Because now everybody is focusing on neonatal mortality reduction because of STG. Lot of newborn deaths are being labeled as stillbirth. So one of the investigations, because in the hospital record it was stillbirth, but when they went and investigated in the home, they said the baby was born and slipped out of the hands of the nurse and fell in the bucket. The baby was alive, but then it was labeled as stillbirth. So I think those are some of the challenges which we are now. So we have to make as much noise about stillbirth, maybe much more, because it's a huge loss to the family, as we do for the newborn deaths. So I'm on both sides. Both are very close to my heart, neonatal mortality reduction as well as stillbirth. Whatever way we can contribute, we will like to contribute and join hands with everyone this year. Thank you so much.
Thank you. Excellent information for us. We have someone in the chat also has asked, how can the private facility participate? Do you have any response to that, Neelam or Dr. Nina? How can the private facility participate?
Participate in what?
Is Rush or Rushe, would you like to ask the question?
Certainly. Good evening to all. Participate in improving like our the clinical staff. How do we educate them, or do we have a toolkit which we can train them on the same basis that the public facility is being public health workers are being trained?
Yeah, see, Stillbirth Society of India is trying to navigate the private health system so that we can train people in the private health system. As government is training the public facilities, we are trying to get to the public. But otherwise, you can always get in touch with any one of us, me, Dr. Tamkin. I think Dr. Tamkin is there. Dr. Tamkin was traveling. Dr. Tamkin, are you there?
Yes.
Yeah.
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 Good evening, everybody from India.
Yeah, Dr. Tamkin, please.
Yeah, I have a slide
give your
to
opinions
US, and
also,
sorry, I
because
could not. I think that is a very important question somebody asked, how to involve the private setup. And because about 60% of the care is being delivered by the private, 60 to 70% by the private setup. So I think whenever I look back, I think sometimes I think we have not achieved much as regards the registration or looking at the real numbers. But what I think Silver Society has achieved is the advocacy part and the sensitization part. Earlier, people were not talking about stillbirths. Now, I'm so proud to see that not a single conference or a CME or workshop is there where people do not have a dedicated session on stillbirths. And people also started talking about bereavement care. So that is also very important. Earlier, we were not talking about these two things. So if everybody becomes sensitized, I think then we can move on to the second step, that of training others. both in the stillbirth, in the prevention bundle, and then the workup that we do after a mishap has happened, the tragedy has happened, and also providing bereavement care with empathy. Thank you so much.
We have antenatal care bundle on our website. So people can go through this and be enriched with the knowledge for improvement from there. Yeah.
Thank you.
And then see, Stillbirth Society of India, we had last year in our last year's conference 2024, August 2024, we had this Hyderabad declaration on stillbirths, where we have concurrence of many societies like FOGSI, like Neonatology Society, where everybody has come forward to work in collaboration for stillbirths. And now this year, Indian Association of Adolescent Health, they have involved our society for their declaration on adolescent health, because adolescent health, if optimized, today's adolescents, they will be tomorrow's mothers. So I think that is a very big change, as Dr. Duncan said, that people have become aware. And now if these societies will involve Stillbirth Society for giving, optimizing the health of adolescents from stillbirth perspective also. So that is a very big change. And Dr. Asna, would you like to comment? Dr. Asna is our one of our executive first 4 people of Stillbirth Society of India.
Secretary and founder.
Yeah. Yeah. Asna, would you like to give some inputs? Maybe she's not able to connect her. Dr. Harsha, I can see Dr. Harsha was very actively involved with us from Delhi with this stillbirth sadness. Dr. Harsha?
Neelam, oh, sorry. Go ahead, Dr. Harsha.
Yeah, thank you very much, ma'am. Am I audible?
Yes, yes.
Am I audible? Good evening, everyone.
Yeah.
My seniors and colleagues. And yeah, we are extremely thankful to Dr. Neena Raina, which, as per Dr. Neelam, was a mastermind of starting Stillbirth Registry. So we were also part of it, and we gave some wonderful figures, and recently we have published our registry data in one of the prominent journals with the help of and the supervision of Dr. Neena Raina ma'am. And we are looking forward to, and of course, after this ministry initiative of stillbirth surveillance, sentinel surveillance. So everyone is looking forward, and everyone is asking how to enter that system. So I think it is yet to be properly or completely functionalized till date, and hopefully we will be launching it soon to collect the exact number of stillbirths all over the country. So that's a wonderful idea.
Yeah, Dr. Bharti. Dr. Bharti is there in for these trainings. Dr. Bharti, are you there? I had seen her name somewhere, but maybe she has left. Yeah.
Hello?
Yes, please.
Okay. Is not doc. It is Dr. Bertie. Bertie. Okay. Can I go, please?
Yes, please.
Okay, I have a question. I want to know why didn't you make one document for stillbirth and perinatal death? Because we know stillbirth is included in perinatal death. In Mali, in 2018, we did one document, a surveillance, a guideline for surveillance for perinatal death and a response. This is my question. Why did you include a stillbirth and perinatal death in one document? Do you understand me?
No,
You don't understand.
Yeah.
Okay, I want to need the help of Sue.
Yeah,
I think Sue speak French. You understand French? If
I'm sorry. I'm sorry.
huh?
Can you repeat your question, Berthy, please? Dr. Berthy?
Okay. My question is why they did a document for only stillbirth, surveillance, and perinatal death. I think it was necessary to do a document which included stillbirth and over perinatal death, neonatal death.
Okay, Dr. Nina understands. Could you respond to him, please, Dr. Nina?
Very, very important question. And I think, Dr. Berthe, you have taken me back into 1985 when we prepared the guidelines on reducing perinatal mortality, which is stillbirths plus first 7 days deaths. But then, as the time has progressed, in SDG, MDG, there was no mention of neonatal deaths either. SDG focus was on newborn deaths. So everybody, to monitor and to intervene, because there was very clear, at birth as well as essential newborn care and sick newborn care, evidence-based guidelines developed by WHO, and those are something which is in place for reduction of neonatal mortality. So every country started to develop ENAP. It was global, adapted by countries. But it's interesting, as WHO, we insisted that they must include stillbirth again as a single digit, because there was no global target for stillbirth. Now the momentum is picking up. So now I see, I was talking to some of the very high-level people in the ministry and other UNICEF and UNFPA partners at the global level. So if you see that the stillbirth focus has started to gain momentum now, but then there are antepartum and intrapartum deaths. And we know intrapartum, for at birth care, there are interventions. For antepartum, we are still looking for concrete evidence-based interventions, where implementation models have been developed. So hence, now that the newborn mortality has started to decline, many countries of a Southeast Asia region are likely to achieve that target. So it is the global targets which really bifurcated stillbirths from early newborn deaths. And newborn deaths, I know now they are congregated and they're clustering around first 7 days. Already the dialogues have started that let's start talking about perinatal mortality rather than newborn separate and stillbirth separate. So what you're saying makes so much of sense, because eventually maternal care intervention and at birth care interventions can reduce both the stillbirth as well as perinatal early newborn deaths. But then, because the global targets were different, there was very little focus on, I'm talking of 2015, very little focus on stillbirth. But now at least every country has included in their newborn action plans, or every newborn, every woman action plan, they have included stillbirth also as a national target to get to single digit. And thanks to, international and national level stillbirth societies who have really brought this focus, and WHO always pushed for it with the countries. Thank you. Dr. Berthe, I hope that I've been able to give you, respond to your question.
Yeah, I can also say just one line, Dr. Berth.
Yes, I am hearing.
Yeah, I will just say that we are especially emphasizing on stillbirths because other things all are given importance to otherwise also. It is the stillbirth which is not being talked about. And in spite of having so much hue and cry for stillbirth since 2011, Lancet 2 series have already come out, and UNIGME every couple of years it is coming. It is still hardly just 0.583% or something like that. I have forgotten the figure, but it's a very, very small proportion which is still being covered for stillbirth. That's why we are emphasizing on stillbirth, because other things will come along, are already being done, and will come with stillbirth. If we are talking about stillbirth and we are seeing stillbirth, some of the early neonatal deaths will be captured as stillbirths only.
Okay, I want to say a couple of things. Beth has put in the chat about a very nice article publication from ICMR on stillbirth in India. And it looks like a very great publication. So if anyone wants to make note of that, it is in the chat. Okay.
This recent one. Yeah.
You sent, okay.
Pooled, this is a ICMR, means this is the biggest research based council of India, ICMR, and stillbirth pooled India cohort. So these two, in this thing they have given them, like it's a analysis of the pooled data.
Okay, excellent, excellent. Well, we are out of time. This has been a fantastic presentation and fabulous interaction with people. Obviously, a lot of interest. And again, we just commend you for the tremendous work that you have done, all of you. Yes, it's one step, but wow, you've taken many steps. You should be very proud of these accomplishments and all of the women and babies that you've touched with this wonderful care. So thank you all. I just am really wowed by this. Thank you, Neelam, for this wonderful presentation. Thank you, participants, for joining and sharing and learning with us. And yep, some thanks in our chat. Make sure and see those. So please, again, join us in a few months when we do another ISA presentation. These are really, I think, fabulous opportunities for us to share the great work that we are doing. Okay?
Yeah.
So we will say,
just if we could get some help, some funding from somewhere for carrying out our phase 2 PVI toolkit part, that will be wonderful. If you can give us some ideas where we can apply for the funding, Sue.
I wish I knew,
the most
Neelam.
Important thing, yes.
I have no words. I am with you. It's a tough time right now, but do not let us just be discouraged. There are still things that we can be working on without being funding. Okay, we can be working in our clinical areas, doing great care, and we hope and we hope that this changes. But we still can be personally giving great care and doing great training, right?
Yes, that we are doing. And we will, of course, we will start testing this on our own, on our individual set of women, wherever we come in contact with our people who have been instrumental in making this.
Yes, yes. Thank you all.
Yeah, thank you.
Appreciate all of you.
Thank you.
Just a piece of suggestion, if ISA, the society people are there, I saw this on a WhatsApp message that this webinar is there, your wonderful presentation. I think if you share it well ahead of time, I could circulate to all my network who are very keen to listen to this kind of journey.
Okay, so, we have recorded this. Yes, I will make note of that, Dr. Nina. We will make sure to receive that. Okay, the recording.
So we can get the recording, Sue?
The recordings are on our website, but we'll make sure that you get them as well. Okay.
Okay. So then we can circulate this recording. Yeah.
Yes, it would be wonderful.
Thank you.
Thank you all.
Thank you. Bye-bye.
Bye-bye.
Bye. Bye.
Thank you, Gina.